Okay. All right. We've got three empty chairs up front. I know you'll have to sit next to Mark, but you know, could be worse. I think they have a few more chairs coming in. So, well, I told Mark I didn't even know we had this many medics, or that so few people were hunting elk. No. Okay, we have a busy morning. And this is going to be, we'll be rolling out the protocol revisions, and I expect to have questions. We can go piece by piece by piece through the protocols, but I think we can cut down some of the action. Now, your protocol is not going to be printed. Every time we print a protocol, we have to change it then about an hour later. So our intent with this protocol is to have it in an electronic format, and it'll be available to you for your own devices on electronic format, and for the devices that are on your rigs, and then probably each agency will print a hard copy for the rig, and also so that you can have it to review and to now. One of the advantages of having an electronic copy is that if we find, and Mark and I have been editing and reading this thing constantly for the last 2 months, and we still find grammatical errors, and you know how I hate grammatical errors, and and we find just little glitches where somehow it didn't get translated. A drug dose that we got changed. Now, this still becomes a very large document, give or take 250 pages or so, which is a lot of protocol. But have faith, we actually didn't change hardly anything that you do. We've actually cut back on a couple things because we've tried to base this on science. I know it's an annoying thing, but okay. So this thing is not working very well, so I'll click it this way. There we go. All right. Starting off in the beginning, and so I'm going to start talking about the setup and the changes, and then we can go back and forth to the actual protocol itself. Now, these protocols, although it says Clark County Emergency Medical Services Pre-Hospital Care Protocols at the top, that is because it's for you. But you'll notice there's a little change. We've got a lot more contributing editors because at least 6 physicians, emergency physicians, and EMS physicians contributed to doing this. Along we've changed a number of things just from science from the Multnomah County. And these are intended to be regional protocols. Now, the Southwest region includes Clark, Cowlitz, Skamania, Klickitat, Wahkiakum, and South Pacific County. All of the medical program directors contributed to this to make a regional protocol, but within each region, within each county, there's some slight variations. For example, one of the county MPDs likes to have morphine, fentanyl, and dilaudid available. You could put a sign on put a big sign up, come and get it, I don't, the rest of, most of us agreed that, a lot of people want to have morphine and they want to have fentanyl available. And that's the choice of the medical program director. In this county, it is not my choice. We've never run out of fentanyl. We've had some interesting close calls, but we've never run out. We always have it. And it's a much safer drug. It has it's better for everything. So, although we regionally said, morphine would be okay to have as an alternative, we don't require that that's carried in any one county. Just like some of the counties still want to have the cyanide kit. The rather expensive drug, which no one knows that, we know it works, but we don't know why, when, and where we should use it. But most of the program and most of the care that's defined in the protocols is regionalized. So if you roll into Cowlitz County, you should be able to function perfectly fine without a special agreement between the Cowlitz County MPD and myself. And the other advantage of this, it makes it simpler for the state. If most of our protocol is the same throughout the region, it makes it quite simple for the state whenever we change protocol or add protocol to review. And that's, I suppose, a worthwhile thing. So, for the protocols, although it says Clark County, it will be really regional. The structure and format changes. The table of contents, we alphabetize the topics. They are hyperlinked. So when you click on it, it'll go directly to it. And that's on your own electronic device or the device that's in the rig. It's a good idea to be familiar with the content, though. First of all, that's why we're doing this today, because we put stroke and CVA is under S, not C. Because it turns out most people think of stroke as stroke. They don't think of, as a CVA. Pleural decompression procedure is under the P section because there are a lot of C's. Eclampsia is in the OB emergencies and in the childbirth section. Okay. Page numbers are contiguous, so we haven't taken the sections and broken them up and numbered the page numbers. So the page numbers they're all contiguous. It's easier to manage that way. 5 sections. Specific protocols, which are treatment guidelines based on chief complaint, procedures, instructions for completing specific tasks, for example, IO insertions, pleural decompression, etc. Then there are county operating procedures, and these are the most specific to each county because Clark County has a lot of we have destination for STEMIs, we have destination for significant stroke, we have etc., and trauma destination hospitals. South Pacific County has 1 hospital. Cowlitz County has 1 hospital. Wahkiakum has no hospitals. They transport out. Klickitat has 2 hospitals, but they're so far apart that they almost run under, so different rules. So county operating procedures are how you function within the county, and that has to be specific to Clark County. Now, some of our operating procedures are the same in both places, in all the counties. Medications. Now, this is a monograph. Each medication that you're carrying will have a specific 1-page, roughly, monograph. And this is really a reference thing for you. I don't expect you to pull it up and read it in front of the patient. And there are simplified medication numbers within the protocol itself, but the monograph tells you what kind of a drug it is, what are the contraindications, what are the similar drugs to it, and we've listed all the drugs as all the alternatives to the drugs as well, so that if we run out of diltiazem, you can have verapamil. And then there's a reference, which has rule of nines, approved abbreviations, etc. And that's also hyperlinked. So when you're in the burn section, if you find rule of nines, you can click on it and go right to it. So now, structure of and format, we have followed as much as possible, and we've checked it over and over again. We've tried to follow the NASEMSA, which is the National Association of State EMS Medical Officers, and the NEMSP, National Association of EMS Physicians, trying to follow their scope of practice for EMTs. And in doing so, basically, whether we call you paramedics or not, you're basically EMTs. We start out as EMR, and then EMT, AEMT, and EMTP, paramedic. But basically, the BLS, the structure of the protocol is that if a BLS person gets there first to the patient, they can start treating within that protocol. That no longer will we have a separate protocol just for BLS. Now, but when they get to the point where they require something that is done by the paramedic, it has to flip to or an advanced EMT. So we start with BLS guidelines and move toward ALS guidelines. In the protocol, ALS interventions have a blue cross. Everything else will fall into BLS treatment and interventions. Medical control concurrence and/or consult will have a big red arrow next to it, in front of it. The medication list. All authorized medications are listed, the dosings and indications, and the alternative. For example, you have abdominal pain, acute abdomen, starts at treat per universal patient care protocol. That's what every protocol now is recommended to start with, universal patient care protocol. Now, we're going to be rolling out the orders to the EMTs as well, starting in January. But tell them not to get anxious, because it won't change what they've been doing anyway. It meets what they're doing already. It's not something special and new. It's just that we have been working under the state BLS protocols was last revised by a committee which Mark and I were on in, I think, in 2004, 2005. So it's really, really old. And it doesn't even have things on it like give aspirin if you think they're having a heart attack, which we now have in all of our protocols anyway. So the abdominal pain, acute abdomen protocol, universal patient care, place patient in a position of comfort. If systolic blood pressure is less than 90, follow shock protocol, and there's a hyperlink to that. We'll get to all this in a bit. Don't allow the patient to eat or drink, and we've tried to establish a map, mean arterial pressure, along with every blood pressure. Now, in a couple places we haven't. And there's a couple reasons for that, so don't get excited. Treat pain per pain management protocol. Treat nausea and vomiting per vomiting and significant nausea. And we will get to all these today. So, plus, each protocol has a separate pediatric section. Now, before, our protocols were, we would have the adult dose and then we would list the pediatric dose along the, in the wisdom of national folk as well as the state, they require now, and they say each protocol should have a separate pediatric section, not an entire redo of the thing, but within each protocol you'd have a pediatric section so that you would specifically go to that, and then there's no confusion that you might pick the wrong dose. Okay, so we should talk about some changes. Why should you even pay attention to this? Okay, a couple of minor changes. In the albuterol, 5 milligram, that was changed from milliliters to the corrected 5 milligram dose. Atropine, we removed it from RSI protocol for pediatrics. It is out now. You only use atropine if someone is bradycardic. And the real treatment of bradycardia in RSI is it's almost always due to hypoxia, so you try to oxygenate the person, get them up to a decent SpO2. Benadryl, the dose is 1 milligram per kilo with a max of 50. In all of the pediatric things, it says do not exceed the adult maximum dose. So Benadryl, I mean, if you have a 50-kilo kid, I think that's probably not much of a pediatric. Decadron. Decadron is an alternative to Solumedrol. Now, we may or may not be carrying it in Clark County. It's just as good, but if we've got the one, this would be an alternative. It's not a, yeah, this could be used as an, because you're allergic to Solumedrol. No, that's not the case. It's just an alternative if you run out. Etomidate. For sedation during RSI, we have increased it to it's still at 0.3 milligrams per kilo, but we now maxed it out at 30 instead of 20. That's based on science. Ketamine, okay. For induction of sedation for RSI, 2 milligrams per kilo, IV or IO, max of 200, so it's based on a 100 kilo person. Sedation or pain, now if you've given 2 doses of fentanyl, if you're using this as an adjunct for pain, the dose is 0.5. 0.3 turns out to be what is known affectionately as a recreational dose. So we will stick at 0.5 IV or IO to a max of 25 at a time. Now, when we get to, and I'll go to the sedation and pain sections right off of the orders to clean this up, but that can be repeated. Now, for severe pain or pain with hemodynamic instability, or when an IV is not practical, you can use ketamine as 1 milligram per kilo IM repeated every 30 minutes as needed. Okay.
That would be without
Yep.
Is there a max on that?
Well, actually, the max is more based on what happens to people if they start having nystagmus. You've gone too far. If they start having real, if they're really weird, you've probably gone too far. This is based on the military experience where you've got somebody who's shot up or injured and you can't start an IV on them and you've got to get them out, or the military likes it because you can continue to fight sometimes. And they just give them IM dose of ketamine, and you know, I guess if they have hallucinations, you know, I'm attacking aliens. What?
What's the onset of action for IM?
About 5 to 10 minutes. It starts sneaking up on you. That's why they say you don't repeat it, and it lasts at least a half hour, if not more.
Now, would you almost recommend maybe for setting the other side?
You say, well, I'm worried they're going to have emergence. Yeah. No, you can't use this for cardioversion. Cardioversion, and we did not go to some places use etomidate for cardioversion. You need an IV. You have to have an IV in somebody to get cardioversion. I don't want you cardioverting people without an IV in, because you might have to do something more exciting, you know, like treat them for VFib or treat them for cardiac arrest. So. Magnesium sulfate. The dose for eclampsia is 2 to 4 grams. Now, granted, you probably won't have that much on your rig. The dose is 2 to 4 grams, slow IV over 20 minutes. Now, so at that time, if you have an actively seizing patient, you're going to want to use some Versed to stop the seizure, because you're not going to sit there and watch her seize for 20 minutes, I hope. You do not need to consider using it for alcohol seizures now. We can't find enough science that says it makes any difference. If you think, yeah. Now, Versed dose for pediatrics, IVIO 0.1 milligram per kilo, IM 0.2 milligram per kilo, IN 0.3 milligram per kilo. Max of 10 milligrams. Now, this is based off the Rampart study and a couple of others that, for pediatrics that that checked doses for, and this is all approved by the pediatricians. Sodium bicarb. We're not adding it to the IV solution for alkalinization for people who have tricyclic overdoses, etc., and Benadryl overdose, because we only carry balanced salt solution. When you put sodium bicarbonate into 500 cc's of balanced salt or whatever, or 250, whatever you're carrying, you end up with hypertonic saline. So just do the push dose, the loading dose, and that's it. You don't have to worry about that from that point on. Thiamine, just a reminder, it's not in the formula anymore, so if you want it, if you have a bad hangover, then you can't steal our thiamine. We don't carry thiamine anymore. So we're not giving it for alcoholism. Verapamil, it's the alternative to diltiazem, so AFib, A-flutter with a rapid ventricular response. 5 milligram IV can repeat in 15 minutes. Now, my own personal experience with verapamil is it causes more hypotension than does diltiazem. That's just to be aware of that. Sometimes it reacts fine to giving some calcium, but sometimes it reacts better to just other ways of dealing with hypotension. Zofran, nausea, vomiting, and to prevent nausea and vomiting with fentanyl administration. So 8 milligrams IV or PO. The actual dosage of that listed in the regional order is 4 to 8 milligrams IV or PO. You can try with 4. My experience is it doesn't work that well at 4, so you probably need 8. Pediatrics greater than 2 years of age, you can use it 0.1 milligram per kilo. Now you say, well, what about vomiting little kids, under 2? Hey, they've got a problem. That's not something that's going to be cured by stopping them vomiting. There's a problem. Yep.
How strong is the contraindication on verapamil versus oral beta blockers?
That's a weak contraindication. Obviously, if Heart Association doesn't like to mix the mix beta blockers and calcium channel blockers, but if they've got a runaway heart and they've been on beta blockers, they're not taking enough, or it's not working correctly. Now, you might be cautious then that might decrease, they might drop the pressure quicker. You might also be aware that, if you have a beta blocker, it's blocking your AV node. The calcium channel blocker is going to block that AV node down, and so you might that might be more likely to get significant bradycardia. Might. I've reviewed almost all the diltiazem cases over the last year, and when it works just correctly, and it drops your, even if people were on beta blockers, a history of beta blockers. And sometimes they were on beta blockers and a calcium channel blocker at the same time, orally. So it's a fairly soft precaution. Okay. So scope of practice by certification level. Why do we have that in? Well, because a couple of reasons. I became aware a couple of cases that happened in the county this year where the EMTs didn't have any concept of scope of practice, or really think about it, and did a couple things that were way out of the scope of practice, even out of the scope of practice of paramedics. Things that really could be construed as practicing medicine without a license. So, and it wasn't that they were evil or tricky. They just didn't know. They just didn't think about it. Your scope of practice. I mean, this is Washington Administrative Code. Certified EMS personnel are only authorized to provide patient care when performing in a pre-hospital emergency setting or during interfacility ambulance transport. Now, pre-hospital emergency setting really means you were called out by 911, right? That's what I mean. When performing for a licensed EMS agency or an organization recognized by the secretary, and those kind of organizations are like search and rescue, and a licensed EMS agency could include the TIMS groups. Within the scope of practice, that is, 1, included in the approved instructional guidelines or curriculum for the individual level of certification, or included in approved specialized training and included in state-approved county MPD protocols. If protocols and regional patient care procedures do not provide offline direction, if it's not in your orders, the certified person in charge of the patient must consult with online medical control as soon as possible. Medical control can only authorize a certified person to perform within the scope of practice. All pre-hospital providers must follow state-approved triage procedures, regional patient care procedures, and county MPD patient care protocols. Regional patient care procedures, the so-called PCPs, usually talk to destinations, where patients should go, how you should be dispatched, how you should respond, where the patient goes. The patient care protocols themselves are up to the county MPD, or now the regional MPDs. And then there are national state things. So in the protocol is a whole list of scope of practice. Now, the N's mean they're national. It's in the national scope of practice. The W's with a star mean they're Washington approved, but they require specialized training. For example, you'll get under continuous positive airway procedure. There's a little W in the EMT line. That a W with an asterisk. That means that in some counties with MPD training, EMTs can use CPAP. It requires that the MPD do the training or provide for the training, and then provide a protocol, and then provide continuing education and quality review. Airways not intended for insertion into the trachea. That's a good line. That's supraglottic airways, so the iGel, etc. And you see there's a W with 2 asterisks. That means that the MPD can do specialized training, and you may recall last year we did literally every EMT in the county training for supraglottic airways, so they could participate in the cardiac arrest as an airway management thing. We're also allowing them under the rules to start to be able to interpret CO2 levels. Now, this is going to be changed as of the first of the year because we have now made this a national thing. So it will become a N for national, and all of the EMT classes that are going on now in the state of Washington are teaching supraglottic airway. So it's kind of a, but within this, and we're not going to go through within this we have all the airway things. You see cricothyrotomy, surgical falls into the paramedic only category, and that's a national thing, even though there are a lot of states that don't allow paramedics to do crics, and surgical crics particularly, and there's a lot of states that don't even allow medics to do intubation. Cardiovascular care, resuscitation, CPR, mechanical, defibrillation so far is still only paramedic, is actually also AEMT. This is defibrillation, cardioversion manual. Now, obviously, automatic external defibrillation is done across the board, and that's a national level. Glucometry is allowed for EMR even in the state of Washington with MPD training and approval. That means that they can do a glucose stick. Cervical collar replacement is allowed for EMRs in Washington, etc. So this document tells you all of the things you can do, all the way down to medication administration, that EMTs can give buccal and oral medication, sublingual. That means they can assist with the patient's own medication. That's been in the rules for a long time. That's nationally. Intranasal, with an atomization device, that's everybody nationally. Meter dose inhalers can be used by EMTs, and nebulizers can be used by EMTs, but essentially that's only patient's own medication. EMTs can use a syringe and needle for anaphylaxis, for epinephrine, and for Narcan. Now, I prefer to have them use intranasal because it's nice not to have a bunch of sharps lying around unnecessarily. Interosseous, EMTs can start IVs. They can also start interosseous with correct training. That's allowed within the state, with MPD training and testing and orders. Now, we don't need it in this county. Pharmacology, a whole list of things, epinephrine for auto-injector, and naloxone, and it's all EMRs, and I like the nerve agent antidote kit for with an IM auto-injector. That's the Mark 1, Mark 2 kind of kits for, you know, nerve gas. You'd have to have the kit available to do it. I don't think anybody's carrying them. They're all stockpiled somewhere, and they're probably out of date by now. Okay, so that establishes the state's scope of practice, which is the county scope of practice. So an EMT following the orders would go down to the point where it falls to the Blue Crosses. They can't they can't cross the Blue Cross line. But basically, that's the basic care. And within that, they've got, so they can treat cardiac arrest, they can treat Narcan, they can treat an opioid overdose, they can treat a number of things, and anaphylaxis, even without the medic there. Now, that's uncommon, it's uncommon but not rare around here, that at least in the far ends of the county. So universal patient care protocol, we simplified it, tried to simplify it from the national scope, because it runs on for about 4 pages. The treatment is basically assess scene state. This is universal patient care for everybody. Assess scene state, safety, hazards, number of patients, mechanism of injury. Request additional resources if needed. Consider declaration of mass casualty if needed. Use appropriate personal protective equipment. Begin initial patient assessment. Determine responsiveness, initial chief complaint. So start out with the ABCs, or CAB if they're in a cardiac arrest. And there'll be a hyperlink to cardiac arrest guidelines if you don't know that already. Secure airway, start oxygen as needed. Control any major external bleeding per hemorrhage, hyperlink control procedure. Evaluate patient responsiveness, motor sensory function in all extremities. Expose patient as appropriate to complaint and to scene conditions, weather, etc., etc. Monitor vital signs, SpO2, ETCO2. So it's included that almost, in all cases you'd be trying to put, or in most cases you're trying to put an ETCO2 on the patient as well. Obtain CBG readings as appropriate. Monitor ECG if appropriate to patient complaint or condition. Establish vascular access as appropriate. Obtain pain severity scale. Perform secondary survey. Secondary survey may not be possible if the patient has critical primary survey problems. OPQRST sample history from patient or caregiver if possible. Follow appropriate patient care treatment protocol if patient's chief complaint or assessment findings change. Key considerations are always listed at the bottom of these things, or suggestions. If a patient is unable to provide medical history, check for medical alert, etc. Other means of documenting medical history. And in pediatrics, use a length / weight-based assessment tool to estimate patient weight and guide medication. Do not exceed maximum adult dosing criteria. Use pediatric assessment triangle, which is the appearance, work of breathing, and circulation, to assist when first assessing a child. Medications will need to be at the low end of dosing scale in geriatrics, over 65. Now, when you come for me, I'll take the full dose of Versed. I'm happy with that. Or in patients with chronic renal disease or chronic liver disease, cirrhosis. So it's always better in the elderly or those with chronic illness to give half of the dose and be able to give another half. It's so hard to suck it out of us old people. Critical patient care. For critical patient care scenes, cardiac arrest, trauma system patient, high acuity medical issue, every effort to perform an interagency review, also known in the fire service as a hot wash, should be made as soon as possible after delivery to the patient to the ED. So it's nice to get of your codes, of your trauma things, to have if you can do it, to have a quick recap. What went well? What could have been better? What did was there anything we missed? Etc. And if it's a cardiac arrest, if you have the printout and the summary of the arrest, that gives a lot of information. Now, I know that that's not always possible, especially interagency, because there's no way of knowing that, if AMR takes a patient from the scene, that they're going to be they're going to be back or be able to get back. But if it's a cardiac arrest, you're going to, that's with ROSE, fire is going to ride in with the 2 or 3 of you can make a quick summary before you rotate away. Okay, let's take a break for about 5 minutes or so. All right. Okay, we're going to go through some specific treatment protocols, things that have been changed, either changed slightly or have been upgraded to follow the national rules. So, first thing, you remember these are alphabetized, so we got abuse and maltreatment starting first. So, pediatric and adult abuse, be alert to be suspicious, suspicious injuries, history of repeated injuries, etc. Treat injuries per protocols, document and report as carefully as possible. Caretakers, description of events, environment, note reaction of all individuals. Support and reassure the patient. Support and reassure be supportive of family concerns. Notify receiving physician of abuse, neglect, or potential of same. We are mandated, EMS providers are mandated to report suspected abuse of children and vulnerable adults. And so they have the listing of child protective services and adult protective services.
Dr. Whitman, there's also a website.
Yes. The question or the statement is there's also a website. There's a website you can use to report. Now, so I've been asked, should I report even if I've told the physician and the nurse? And the answer is yes. I'm sorry?
Gatekeepers? It's a program in Clark County.
Yes. The gatekeepers I don't know that number, but is that on a website? Okay. All right.
When was the last time I called Adult Protective Services? They didn't blow me off, but they said they don't take reports from EMS anymore. Why is that?
Because they don't know the law. You know, if you hadn't reported and something had come up, they would have blamed you for it. So, you know, that's how it works. You know, it works out well. Yeah.
So still call.
Yeah, still call. So, I mean, you've done your duty according to what we understand the law. Altered mental status and coma. Treat per universal patient care. Treat underlying cause if known. And your underlying causes are hyperglycemia. Check blood glucose level, typical and remember the EMR can check blood glucose level. If glucose is greater than 250 with symptoms of dehydration, vomiting, abdominal pain, or altered level of consciousness, then they need a fluid challenge. Obviously, that has to be a medic. Or it has to be a medic. An EMT can start an IV line if they've had the IV training and approval, but other than a TKO, that's all they can really do. Now, that's usually not a problem. Hypoglycemia, determine blood glucose level if less than 60 in a non-diabetic or less than 80 in a known diabetic. If the patient can protect their own airway, they get oral glucose or something that has glucose in it or any protein in it for that matter. If patient's unable to protect airway, infuse dextrose 10 grams. Now in Clark County, you're going to carry D10. In other counties, they may not have gone to D10 yet, but the answer is here. It doesn't make any difference because they said dextrose 10 grams and then repeated as needed up to a total of 25 grams. Check blood glucose after 5 minutes, repeat. Patient remains and repeat. You know, if no IV can be established, glucagon 1 milligram IM. Now in counties where they don't have paramedics or AEMTs, or they're not easily available, the MPD could approve IM glucagon given by an EMT, but it would have to have training. But I mean, that's not a problem. Now, that's unfortunately now one of the more expensive things. Glucagon is, I think, is in this $300 to $400 an amp rate now. Yeah. Okay, now suspected opioid overdose with respiratory depression. If a BLS provider or difficult IV access give naloxone 2 milligrams IM or IN every 5 minutes up to 8 milligrams total. Now, that doesn't mean, now, you have to have suspected. We get this all the time. You got a cardiac arrest. 60-year-old lady at home with history of diabetes and coronary artery disease, and, you know, why would we give them Narcan as the first thing off the bat? You know, it's especially if they're in a cardiac arrest, not a respiratory arrest. I mean, what do opiates give you? They give you a respiratory arrest, and then you go to a cardiac arrest, not vice versa. So if you suspect an opioid overdose, treat it. Now, then, with the Blue Star, the Blue Cross, so medics, IV naloxone 0.5 to 2 milligrams. If you have a person who's totally apneic by the time, or almost apneic by the time you're going to go ahead and give them the 2 milligram. Now, some MPDs live in fear of people waking up and becoming violent, having terrible withdrawal. I figure, well, if they're almost dead, maybe that's why they're having their terrible reaction. And now you've woken them up. Or because they'll wake up and refuse to be transported. This is not a problem. First of all, you don't have any problem, except for methadone overdose, you don't really have any problem waking someone up from, with suddenly withdrawing an addict, because they won't seize, they just feel terrible, they'll hate you, and they might be a little aggressive. But, you know, so a lot of guys like to titrate their drugs to people so that they don't get, so you can package them and get them in. However, the downside of having somebody die of a respiratory arrest, but particularly when you have carfentanil and you've got other things out there now, is not worth taking the chance. So if you have someone, I don't want you to give big doses of naloxone to somebody who's just simply high. You shouldn't be treating them for being high. You should treat them for respiratory arrest or near respiratory arrest. So, if no improvement, repeat naloxone up to a maximum of 8 milligrams total. And methadone overdose can sometimes take a lot more. If now this is in the altered mental status still, it doesn't read as clearly as I like. If patient is or becomes combative, consider sedation. That's not after you wake them up. That's if they're, you know, if they're altered mental status and combative, then we sort of fall into the behavioral emergencies. Pediatric medications are listed separately. Dextrose in specific amounts, glucagon specific amounts up to a maximum 1 milligram, naloxone 0.1 milligram. Do not give to newborns. Newborns you can treat if they're respiratory, if they're respiratory depression, go ahead and treat them by ventilating them, oxygenating them. Problem is, babies will seize if they get naloxone sometimes, and that's the last thing you want to have in the middle of a infant resuscitation. Pediatric fluid challenge, 20 mil per kilo. Repeat 1 time. We did cut that down a little bit. What used to be 2 times. So you could have three doses. I figure you need to go more than 2, contact medical control. Behavioral emergencies, transport to alternative care. Now, we spent most of last month talking about this, so we won't beat this to death. Transport to alternative care. There is a facility who allegedly is going to start taking patients, but to my knowledge, they haven't taken anyone yet. Matter of fact, they're mostly sending people away who don't fit the criteria. But that's coming, I believe. So the inclusion criteria has to be a 911 dispatch, age 18 to 55. They have to be voluntary, willing to go to an alternative destination, cooperative, non-combative, normal level of consciousness, no dementia, patient able to perform activities of daily living, means they can feed themselves and go to the bathroom. So, exclusion, no new onset mental illness. If somebody is acutely behaviorally disturbed today and they were fine yesterday and they have no history of mental illness, there's something else going on. Schizophrenia and other things do not happen overnight to 40-year-olds. So, and no overdose, because this isn't a medical facility. They can't take sick people in that sense, medically sick. No trauma requiring treatment other than a bandage. No loss of consciousness or seizure in the last 24 hours. Once again, it's low-level medical. No pregnancy. They just can't deal with that idea. No evidence of acute medical or traumatic problem, and interestingly, no anticoagulants. Vital signs have to be within a given range: heart rate 50 to 100, blood pressure 100 to systolic 100 to 180, blood pressure diastolic less than 100, respiratory rate 12 to 24. You got quite a bit of wiggle room there. SpO2 at least more than 92%, temperature essentially normal, blood glucose wide range 70 to 300. Assure scene safety, approach the patient calmly, protect the patient bystanders, restrain protocol if indicated. Well, if you need to restrain the patient, you can't take the patient to the alternative facility. So this is the general care of behavioral emergency. Obtain history, physical, mental status, assess and treat medical conditions per EMS protocol, determine if eligible to transport to either Rainier Springs or to the Clark County Crisis Center when it opens. Contact receiving facility and tell them you have an EMS patient and can they accept. If they say no, you go to the closest appropriate emergency department. If they say yes, then you contact medical control for confirmation and just let them know you're going there. Document inclusion criteria, provide a receiving facility. All patients will be assessed and evaluated by EMS regardless of your transport status. Specific red flags that this may not be a psychiatric condition: waxing and waning level of consciousness, abnormal vital signs, dilated pinpoint pupils, first psychotic episode over the age of 30, acute onset over hours or days, consider substance abuse, etc., head injury, psychiatric signs and symptoms, mood disorder, depression, mania, suicide ideation, anxiety, thought disorder, hallucinations, pressured speech. That's just a list of things. A lot of medical illnesses can mimic and cause behavioral type emergencies, including hypoglycemia, etc., head injury, CNS infections. All right, a new section, sort of signs of the times. This is in keeping with the national scope. A new section on blast injuries, something we have not had to think about for a long time. And we go through injury pattern, primary, secondary from projectiles, tertiary displacement of the victim, being thrown around, blunt penetrating trauma, quaternary other injuries from the blast, crush injuries, burn, asphyxia, toxic exposures, etc. Treatment consideration: manage hemorrhage per protocol. There's a hyperlink to hemorrhage. Secure airway. Early airway control is vital if there's a thermal or chemical burn to the airway. Breathing. oxygen target of 94 to 98. I think we've corrected everything within our protocol that says our target for O2 is 94 to 98%. Assist respirations, cover open chest wounds, etc. Large bore IV access, treat shock per protocol. There's a hyperlink to shock if you don't remember that. Disability, treat traumatic brain injury, hyperlink to traumatic brain. Immobilize the spine, hyperlink to our spine protocol. Manage amputation, hyperlink per protocol. A new change, brief resolved unexplained event, a BRUI, which is the synonym now for ALTI. Little kids, little babies, infant less than a year of age associated with at least one of the following: an event lasting usually less than a minute, enough to cause the caregiver to call 911. Cyanosis or pallor, absent, decreased, or irregular breathing, marked change in muscle tone, all of a sudden floppy baby, altered level of responsiveness, all of a sudden floppy baby. Now it's okay, or probably okay by the time you get there. Support ABCs, follow airway management, respiratory distress protocols, hyperlinks. Obtain and document any complication of pregnancy, birth date, gestational age, etc. Document description of the event, including symptoms, inciting event. Place on cardiac monitor and follow dysrhythmia protocol as needed. Assess blood glucose. Transport via ALS to an emergency department, even if the infant currently appears in no distress. If the parents say, no, we're not gonna go, mandatory online medical control contact. Put them on the phone with, tell the doc what's going on, put them on the phone with the doc. BRUI is a group of symptoms, not a specific, so essentially this is no different than what the ALTE was in the last set of orders. They just changed the name on us. I guess, you know, they went from the A's to the B's. Next year it's going to be a C word, you know, chronically or chronically recurring unexplained event, something like that. Most common in infants under 1 year of age, but can occur up to 2 years of age. So many infants appear normal. Oh, you're there. Consider non-accidental trauma. So this might be, you might be suspicious that maybe somebody whacked this kid or did something. Serious underlying illnesses can include pneumonia, bronchiolitis, seizure, sepsis, intracranial hemorrhage, meningitis, little things. BRUIs are more frequent in premature infants and infants with other health conditions, cystic fibrosis, congenital heart disease, etc. All right. Now we changed the cardiac arrest things a little bit. Not that we changed how you're dealing with cardiac arrest, but in the orders to make it so that we started out with the initial management, which is establish unresponsiveness, identify absent of pulse and respirations, continuous CPR for 2 minutes if you estimate the downtime is more than 5 minutes. If less than 5 minutes, or if adequate bystander CPR, do CPR until the AED and monitor is applied. Applied EKG leads, defib pads, analyze and follow AED instructions. So that's all basic life support that can happen with your EMTs. If there's a medic there, paramedic interpretation. So follow and analyze, so defibrillate as needed. Then continuous CPR for 2 minutes, rhythm analysis again. During that period, after the initial shock or the initial rhythm analysis, an SGA is put in, O2, capnography, and an IV is started. Now that can all happen with EMTs. Now happily, most of the time, we will have a medic there at that time too. But the EMT can certainly do the initial shot and the initial treatment. So for outlying areas where you have volunteers, yeah, they'll cover it. Now, use a weight-based system for treating a pediatric cardiac arrest. If patient not responding to treatments as follows, consider death in the field. Well, we're not going to jump to that one yet. So what I'm going to do is get out of this, and I'm going to go to, so we'll show a couple of, oh, where is that thing here? Okay. All right. So we want to go to cardiac arrest, initial management. Magically, it jumped right to that, see? Continuous CPR for 2 minutes.
You are welcome.
Okay, now, so you say, well, gosh, this is not all of the, well, okay, here we go. Now we go on to cardiac arrest asystole. That has to be determined by the medic. Because if there's no medic there, they're going to continue to do CPR for 2 minutes, other management, do rhythm analysis, and the machine in AED mode will say shock advised or no shock advised. If it says no shock advised, you just continue going. You're assuming it's, I mean, they have to assume it's either asystole or there's a rhythm present, and so you check for pulse, and or it's a PEA. They can't tell, right? It's only the medic is going to be able to say that this is asystole or this is not asystole. In your asystole, so we bumped right to you start treating with epinephrine, just like you always do. So we haven't changed your protocol. You jump to epinephrine. We are looking at the total amount of epinephrine. We haven't changed the rule yet. There's a suggestion there's a suggestion we may be wanting to limit epinephrine to 3 to 4 milligrams total, because we seem to start too many hearts way down the line with 5-6 milligrams of epinephrine, and by that time they don't have, they all end up dying of anoxic brain injury, and we think the epinephrine may, but we haven't changed that yet. But think how easy it'll be to change it now. We just put it in there and send it out electronically. So we continue epinephrine every 3 to 5 minutes. We haven't put a time limit on it. We're still fighting that among the medical smart people. And pediatric patients follow adult algorithm and epinephrine given. Notes and precaution. If an unwitnessed arrest and no obvious signs of death, proceed with resuscitation and get further information from family bystanders. The obvious signs of death, pulse form, etc., etc. Follow death and dying protocol. Oh, look. Well, made an error. Uh-oh. We got to correct that hyperlink. Wah wah. You see, that's why we have to do this electronically, because it's okay, we came real close. Here we go, death in the field. So it goes through all that stuff on how to call somebody dead. And then it talks about traumatic events and limited resources, so it works for little agencies as well as big agencies. Victim of arrest should be determined dead in the field, not transported if asystole initial monitoring, and hasn't responded to 3 cycles of asystole. There's no change from your previous one. Asystole upon initial monitoring and who is not, in your judgment, resuscitatable. ETCO2 less than 9, pulseless electrical activity, etc. They're all listed. It's no change from original. And they still require that you make medical control concurrence, because strictly speaking, only a physician order can have you terminate the resuscitation. And we've got most of the ED docs, I think, attuned to the fact that, yeah, when you say, yeah, I want to call this person is really dead. All right, so I want to get out of this one. Oh, no, I'll go back. Okay, so you say, well, what about the rest of my cardiac arrest? Okay, pulseless electrical activity, hey, big change here, epinephrine, right? And then we've got pediatric doses, and then we've got treat other possible causes, and this is no change from before. But within this now, and I won't even test it, I'm just going to assume it's correct, acidosis, sodium bicarbonate, cardiac tamponade, consider hospital transport, because you can't do much other than CPR on these. Hyperkalemia, you've got a hyperlink to hyperkalemia, hypothermia, hyperlink to hypothermia, hypovolemia, shock protocol, tension pneumothorax, needle decompression. We have some changes in needle decompression we'll get to today. So then, by gosh, it goes to VFib, pulsus, VTAC. Epi, amiodarone, if amiodarone is contraindicated, lidocaine. And one of the counties does not like amiodarone. He only uses lidocaine. So that'll work for them too. It's all in the orders. Multifocal wide complex tachycardia, magnesium. Epinephrine, more, CPR, more epinephrine, more amiodarone, up to 150. So no changes in your protocol for that. It's just in a little bit different format. And then pediatric doses. Now, airways should be addressed with minimal interruption to CPR. Ventilation rate should be 8 to 10 breaths per minute. If patient remains in persistent VTAC after 3 shocks, reposition defibrillation pads anterior posterior. Interesting, District 6 had a very interesting cardiac arrest on a 17-year-old on Halloween. And they put on the defib pads AP. This was a skinny, 17-year-old, so it worked quickly. And they got, they had a conversion. We had no idea how long this kid was down either. Had a conversion, electrical conversion within, I think, the first shock. AP. I mean, AP is really the way to go if you can. But I just realized that, it's difficult to do on most cardiac arrests. But we still encourage that, especially if they're refractory to shocks. Sodium bicarb is not recommended routinely for cardiac arrest, but if you have a known tricyclic antidepressant or a patient with hyperkalemia, it's a good idea, and in a prolonged arrest, okay, as well. And the dose is always a 1 milliequivalent per kilo, and you can repeat that every 10 minutes. Return to spontaneous circulation now. Titrate oxygen to, so now you've got a clear, we should put this in a checkoff list, but right now it's clearly, intubate as needed. If the patient, and what that means, if the patient wakes up and begins, pushing you away, you probably don't need to intubate them. But if they don't wake up and you're going to transport them, they probably need to be intubated. Titrate oxygen to target of 94 to 98, ETCO2 to maintain at the normal rates, 35 to 40. Try to get their blood pressure up above 90. So a MAP of 65 or blood pressure greater than 90, it's usually 95. And you can use pressor agents for that as needed. Usually they respond to fluids. 12 lead EKG, transport obviously to the hospital. Okay, so I'm going to get out of this one again and go back to the other one. Okay. Stable tachycardias. Now, the patient does not have signs or symptoms of poor perfusion caused by dysrhythmia. So, altered mental status, ischemic chest discomfort, acute heart failure, or signs of shock. These are all unstable tachycardias. Universal patient care, 12 lead, narrow complex QRS. So, vagal maneuvers if refractory adenosine, adenosine, adenosine. No change. Irregular rhythm. AFib or A-flutter with a rate greater than 140. Generally speaking, it's not significant. Generally speaking, you probably shouldn't use medication to treat a heart rate of less than 140. Because look for some cause. So in reviewing the diltiazem cases, we had a couple of interesting ones. Patients, 68-year-old female, complains of rapid heart rate for days, complains of nausea, vomiting, and diarrhea for 2 weeks. Heart rate's 160. And known AFib. So what's the treatment for this person? Not diltiazem. Exactly, the diltiazem didn't do anything. This is an educational thing. I mean, you think, look for the cause. So monitor patient, consider cause. I can't tell you how many sepsis were in that group either. Sepsis, shock, dehydration. So then diltiazem to a max of 20, and you can repeat to a max of 25. Alternative is verapamil. Also to a max of 20. That is given at small doses. Now, it says, don't use in WPW. Okay, I was going to make was going to be pretty vicious because we used the diltiazem in quite a number of wide complex, and we'll get to that one next, wide complex here. We're using quite a number of wide complex and AFibs with and I was a little bit anxious about it until I reviewed all this. And in almost every case where we're using a wide complex, especially AFib with a wide complex or A-flutter with a wide complex and a rapid ventricular response, These are older people. These are people well over 65. I couldn't believe there were so many 80-year-olds out there. And you know, I mean, with cardiac issues. Well, I guess why not? But I guess I don't want to think about that. I'm a lot closer to that than you guys are. So, but they all did fine, and the ones that were appropriate to use diltiazem had a good response. Certainly by age 65, you should know if you have WPW, Wolff Parkinson White. So it's really only the onset of wide complex or wider than normal QRS complexes associated with delta waves in younger people who have not been yet diagnosed as WPW. Now, interesting enough, the case that I told you about, the District 6 case, the kid's underlying problem is Wolff Parkinson White. And he'll ultimately have to, he's doing well, by the way, he ultimately will have to have an ablation done, But the problem with Wolff Parkinson White, and he probably went from a Wolff Parkinson White tachycardia into atrial fibrillation into degenerated because it's going just through the reentry cycle into a ventricular fibrillation. So be suspicious when you have atrial fibrillation or a wide complex or a tachycardia in a younger person. I would not really be very anxious about older persons because they should know by that time. Now, almost all these cases know that they had atrial fibrillation to start with, or a history of atrial fibrillation, and then they end up with a wide. So wide complex tachycardias, regular rhythm, QRS is monomorphic. If you suspect VTAC, treat it as VTAC. Don't say, you know. And so amiodarone, if the patient is stable, if you think they have VTAC. You still have the okay if you have monomorphic and you think, oh, this has got to be supraventricular. You could try a dose of adenosine. Now, adenosine should not be used if you think you have Wolff Parkinson White also. But that's been in your orders for a long time. So, if it's an irregular rhythm, if it's torsades, treat with magnesium if you think it's torsade. If it's AFib or A-flutter with a rapid rate, diltiazem or verapamil, but not in patients with known WPW. In that case, I would say, gosh, I'm going to call the doc and see what they want us to do. Pediatric patients, it's not same orders. It's not as difficult. The adenosine dose we have here. Sinus tachycardia. Think of the cause. Usually, it's dehydration. Wide complex QRS. Monomorphic, we would do adenosine because it's probably a supraventricular tachycardia. If it's VTAC, kids can have amiodarone too if it's stable. Now, so all doses of adenosine should be reduced to 1/2 for cardiac transplanted persons, patients who've had a heart transplant. patients on Tegretol or Prosantin, Agrinox, or if you're administering it through a central line, if you've gained access to a PICC line, for example. However, so that's not a change. Don't use adenosine in patients with WPW in atrial fibrillation with wide count. Well, you shouldn't use adenosine in wide in WP in AFib anyway. It's contraindicated in AFib in general. Asthmatics may get a little reactive airway with adenosine. Calcium channel blockers do not treat, they don't convert AFib flutter, but decrease the ventricular rate. Sometimes when you decrease the rate, it automatically converts to a normal sinus rhythm, but it's not meant to convert. Unstable tachycardia, no change. If they're unstable, they have signs of poor perfusion. Immediate synchronized cardioversion, we have specifically said if the patient is conscious, provide sedation, but don't delay cardioversion for sedation, because you can give the Versed after cardioversion if you didn't give it beforehand, but it has to be right afterwards for it to be retrograde amnesia. I would prefer them to have it beforehand. Like I say, I don't really want you cardioverting people without having an IV in them. And repeat cardioversion if refractory. If they're refractory on the second time, you should consider that there's something else going on, and maybe they're dehydrated, maybe they've got sepsis, maybe they've got something else, and you need to do a fluid challenge before they're going to respond. If they don't convert, you can also consider amiodarone IV, just like you can with stable VTAC. Repeat synchronized cardioversion then, and then try more amiodarone if it doesn't work. If this is multifocal torsade, they need magnesium, etc. Hyperkalemia. Now we've changed we simplified the orders. Suspect in known renal failure or dialysis patient. Other patients predisposed to hyperkalemia, muscular dystrophy, paraplegia, quadriplegia, crush injury, prolonged immobilization of patients that have sustained serious burns more than 48 hours ago. Now, we recently had a patient who had a significant, was in the burn center 6-8 months ago, and now got another burn, and is, the bad thing is don't smoke in bed, and was appropriately treated, but and then was thought, oh well, maybe this patient's going to be hyperkalemic because she had a burn 8 months ago. No, that's okay now. So they didn't need to use rocuronium to intubate her, but it's okay. At least they're thinking about that. So 12-lead EKG, signs and symptoms of hyperkalemia: tingling numbers, paresthesias, flaccid weakness, EKG changes, peak T waves, prolonged PR interval, wide QRS, PVC, bigeminy, VTAC, and VFib. That's in sort of progression as you become more hyperkalemic. Universal patient care protocol: establish IV. Fluid of choice is balanced salt and not lactated ringers, because the lactate works just like bicarbonate. It's just like the bicarbonate. If you put your calcium in with bicarbonate, it makes rocks. Okay, Well, that's what lactated ringers theoretically, now, it'd be Little Rock, so it's not. So your IV choice is balanced salt and calcium gluconate, and the alternative for that is calcium chloride if we run out of calcium gluconate. Flush the tubing, sodium bicarbonate, 50 milliequivalent, slow IV push, and then albuterol. And now albuterol you can give at the same time, because that's just by MedNab. Follow protocols for dysrhythmia, rapid transport. Notice that there's no more insulin and glucose. The reason is we've never used it, because these people are never at home with their bottle of insulin. And so many people take long-acting insulins, they don't have regular insulin, and it's just not worth the effort. We'll do that at the hospital. You can take care of them just fine. Albuterol lowers you by 0.5, and you can repeat it. Calcium gluconate stabilizes that membrane just by putting calcium back into the system, into the heart. Sodium bicarb shifts your potassium. So you can repeat all these things. If you're traveling all the way from North Country, you can do more treatment. We do treatment all the time, more treatment all the time. The real answer is they need to be dialyzed. All right. Toxemia. We've pushed toxemia a bit. There's certain areas we seem to have about 2 or 3 cases of toxemia a year, which is more than I would have expected, but actually much more than they seem to have in Portland, and much less than they have in Cincinnati, Ohio. So it's probably determined by a lot of things. Moderate to severe preeclampsia is hypertension, headache, visual disturbances. They have scotomata, like they do, flashes of light, like before. This is caused by probably spasm of small arterioles in the cerebral cortex and the visual cortex. It's like migraine sufferers get. Epigastric pain, dyspnea, cyanosis, and then eclampsia has any of those things along with seizures, or they could be postictal by the time you get there. Treatment, if they're actively seizing, is Versed, followed by magnesium sulfate, and the loading dose is really 4 grams IV slow over 20 to 30 minutes. And then the OB-GYNs say it's another 4 grams over the next hour. Now, the only downside of magnesium plus Versed is sometimes you get some respiratory depression. Not probably at the dose you'll be doing. The endpoint of magnesium sulfate therapy is absence of reflexes. So it's easy to test. It's easy to test it's easy to see if somebody is really pre-eclamptic, if their seizure potential is there, they have hyperactive reflexes. You just tap them on their arm and they jerk, or on their patella. In that case, I'd probably pre-treat them, but that would be a medical control consult. Seizure, no problem. And you don't have any problem with the old dose of magnesium at 2 grams, and if you have enough, 2 to 4 grams is the loading dose. Now, also be aware we have, of course she probably is delivered now, we had a pseudo-seizure patient who was treated twice for toxemia. But, her pseudo-seizure was not responsive to toxemic treatment. Pain control. Universal patient care protocol, location of pain, severity using numeric scale, consider, treat underlying cause of pain, use non-pharmacologic pain management, i.e. position of comfort, hot cold pack, elevation, splinting, paddings, wound care, etc. And then we've added this one earlier this year, no change, Toradol, ketorolac, 30 milligrams IM or 15 milligrams IV. Don't repeat. Not for cardiac chest pain, and the trauma patients, the trauma surgeons don't want it used in trauma system patients. There's really no reason not to. They're just twitchy about. They think it can, because it's antiplatelet. They think, oh, if we operate on the patient, maybe they're going to bleed more. My answer is tie your knots tighter. It really hasn't made any difference. All the studies show that, but we want to be nice. We want to play with the rules, and they're just anxious about it. So they'll probably change that in a couple of years. Use in patients 2 to 6, may be used in patients 2 to 64 years of age. So don't use. It worked out great for me, but and I'm well over the 64, but that's the cutoff because that's what the manufacturer says. Contraindicated in patients with known renal or liver disease or allergies to non-steroidal anti-inflammatories, including aspirin, possible pregnancy, anticoagulant use, bleeding disorder, trauma system injury, altered mentation. Now, the reason we threw it in for altered mentation is if you've got somebody that may be an intracerebral bleed, I really don't want to anticoagulate them, okay? Opiates. Avoid use of opiates in chronic pain syndromes, including migraine headaches. If you've got somebody who's really whining and crying and because of the severe migraine headache, call the ER doc. Call medical control and talk to them about it, instead of just giving them fentanyl. For an adult, give it in 50 microgram increments every 3 to 5, titrated to relief of pain. Up to 3 microgram per kilo total dose, but we try to keep it no more than 200. It should be a other direction of error, 200 micrograms per hour. Rapid injection can cause respiratory arrest, chest rigidity, so give it slowly. Same as any other drug. Ketamine, we talked about it a little bit already. Adjuncts with opiates, 0.5 milligram per kilo. Max at 25 at a time, may give at least 2 doses. You can continue. Severe pain with hemodynamic instability, 0.5 milligram per kilo IV or IO, max of 25 again, may repeat every 10 minutes as needed, or if the patient develops nystagmus, agitation, or ventilatory compromise. 1 milligram per kilo IM, repeated every 30 as needed.
What intranasal?
No. Not for ketamine, no. I'm not giving it intranasal yet. Indications for acute, okay. Why to use pain control? Well, facilitate packaging, transport, prevent exacerbations, and alleviate discomfort. Facilitating for nausea, don't forget you have Zofran and at 4 to 8 milligrams IV if they're nauseated after you give them the fentanyl. Versed for muscle spasms associated with pain. And ordinarily we think about that as for back spasms, but you can have severe muscle spasms of from a hip fracture. Pediatric patients, you have your doses there. 4 for all pediatric patients. For ketorolac, remember 2 to 16. That's the pediatric age group that can have it. Fentanyl, don't administer opiates if the patient's blood pressure is lower than normal for child's age, and because that's a specific thing, we have them listed. And then Zofran, they can have Zofran as well. We just went through ketamine already. Oh, is this pediatric ketamine? No. Okay, seizures. Universal patient care protocol. If the patient's in status, continuous seizures, Versed, no change. If no IV access, Versed. That's an adult, 10 milligrams IM. Maximum of 20 IM. Now, the Versed, someone asked how fast does Versed take when you give it IM? Probably 2 to 5 minutes it begins. Check blood glucose, treat per altered mental status, magnesium sulfate for eclampsia. First-time seizure patients require medical evaluation, even if they wake up and they say, "Oh, I'm feeling okay." If it's their first seizure ever, that means bad things. There's bad things happening. We took out magnesium for alcoholic seizures. Pediatric patients, we have the same thing. Versed is 0.3 milligram IN. It should be 0.2 milligrams IM. Repeat until the seizure stops, and we should have a max dose there. Febrile seizures are usually between the ages of 1 to 6, usually closer to 1 to 3. It's seldom after age 3. Versed, and use acetaminophen suppository if they're really hot. If the patient's not actively seizing, if they're waking up, an IV is not required. All hypoglycemic or first-time pediatric seizure patients have to be transported. So if it's their first febrile seizure, they still should be transported and seen. Now, postictal means that they're probably not responsive, but they're waking up. They may be inconsolable as children. If their eyes are always deviated to one side, they're still seizing. Shock. Hypovolemia, control external bleeding, 2 liters of isotonic fluid as rapidly or until blood pressure is 90 so the MAP is greater than 60. Or they develop neck vein distension and or pulmonary valves develop. Normal mentation. So a fluid challenge is 20 cc's per kilo for children, 20 cc's per kilo for adults. It's just that with adults who have a potential of going into congestive heart failure, we don't give them, we don't give the 100-kilo guy 2 liters rapidly as the first test. If he's 80 years old, he may well develop pulmonary edema. That's why we give a fluid challenge, and ordinarily we think 500 cc's, maybe for old people, give 250, give 250, give 250. 500 cc's is a can of Coke. That doesn't seem like a lot. Okay? But it may be too much for somebody who's old and not cardiac functioning well. If head injury and shock, we use a fluid challenge to target rates 100 to 110. Distributive sepsis, distributive shock, sepsis, neurogenic shock, begin the fluid challenge. We want to maintain our blood pressure of 90, greater than 90, with a MAP greater than 60. We would go to norepinephrine or alternative epinephrine if you need a pressor agent. Theoretically, norepinephrine is the preferred medical treatment for or pressor. However, a lot of the ER docs like to use epinephrine. What I would use as your judgment thing is if the patient has a tachycardia, stay with norepinephrine because it won't drive heart rate. If the patient's bradycardic, think about putting epinephrine on it. Okay. Cardiogenic shock. Once again, fluid challenge. Go on the light end of fluid challenge if they're older. And once again, norepinephrine or alternative epinephrine. And I would use the heart rate as your determining factor there. Now, sometimes in cardiogenic shock, we end up running a norepinephrine drip and an epi drip. Epi to drive the heart rate, norepinephrine to be the major pressor. Hypoadrenal shock, Addison's crisis. Now, you have to know that they are hypoadrenal, so they're going to get that from their parent or caregiver. We have just recently had contact with a school nurse who told us about one hypoadrenal child. Or you can be suspicious that they might be a problem if you know that they're on a high dose chronic steroid, because that means that they've suppressed their adrenal glands by exogenous steroids. So in that case, you could suspect it, particularly if they got sick and couldn't be taking their pills, or for some reason ran out of their prescription and didn't think about or didn't know that they were going to be then in a hypoadrenal crisis. Well, you know, it presents as severe shock. You don't have to worry about it if they're not in shock. So you treat them for IV fluids and then just give them a good dose of Solumedrol or Decadron if you happen to have that as the alternative. Either drug works fine. General considerations, no change. So, syncope. This is a new added one to keep up with the national standards. Syncope is the loss of consciousness and postural tone resolving spontaneously without medical interventions. Most of us call that fainting. Typically is abrupt in onset, resolve quickly, may find patient awake and alert. Pre-syncope is a prodromal symptom of syncope as nearly, quote, nearly blacking out or nearly fainting. So if you have a clearly identified cause of the syncope, i.e. you've got them on a cardiac monitor and they've got a dysrhythm, treat that. If they have continued neurologic changes, consider this might be a stroke. If they have altered mental status changes or coma, go to the altered mental status protocol and treat them for that. Universal patient care, direct your main treatment to abnormalities discovered in physical exam. So airway, oxygen, evaluate hemorrhage, establish IV access, fluid bolus, cardiac monitor, 12-lead, monitor and treat arrhythmias. And basically we feel that all patients having syncope deserve hospital level evaluation, even if they appear normal at the times. Your high risk causes are myocardial infarction, aortic stenosis, hypertrophic cardiomyopathy, pulmonary embolus, thoracic aortic dissection, lethal dysrhythmia. All of these are ultimately fatal. Could be. Neurovascular, intracranial hemorrhage, transient ischemic attack, or stroke. Most people will fall in the cardiac dysrhythmia thing, most of the older people. Okay, how many more of these do we have in the treatment? Let me see where I am on this number. Oh no, we're getting there. We got about another 45 minutes to go. So let's take a break. Okay, it's interesting that we're going right on to vomiting significant nausea now, because we just were having a discussion about having an alternative to ondansetron, because AMR says they're not having it for a while, and I can't figure out why there's any problem, because all the other agencies have tons of it. So we'll have to deal with that first, while we look perhaps for an alternative as well. But vomiting significant nausea, no change, except you can give the oral tablets if they're not that sick. And then ondansetron, 48 milligrams IV slow, and you can give with fentanyl to prevent nausea. Pediatric patients, the dose is 0.1 milligram per kilo. Look for the underlying causes, because head injury, increased intracranial pressure is not going to respond to much of anything for nausea. Shock and hypotension, well, stroke also might not respond too well. Communicable disease, norovirus, other disease processes. Now, here's one we borrowed from a couple of people. For the not terrible nausea and vomiting, but just sort of consider offering the patient an isopropyl alcohol swab. You open it up and you sniff it. Self-administered, deep inhalations, and you can do that up to 3, and on a whole bunch of people it works. Now, I don't know what the science of that is. Maybe they think they're in a doctor's office and they're safe. I don't know, but it does work. I'm not saying that it's going to be, but if someone is just vomiting and vomiting and vomiting and vomiting, forget it. They need medication. Okay, now we're going to go on to Clark County procedures. Now, airway management. I'm not going to spend a lot of time on this one because it's quite long. Go ahead and spend your time. I said we're going to be doing more and more and more. Suffice it to say, there's no significant changes in your protocol, except that we're emphasizing pre-oxygenation. So BVM if inadequate ventilation is present. CPAP considered for medical patients complaining of moderate to severe respiratory distress. End-tidal CO2 on all intubated patients, and I like to see an end-tidal CO2 on most everybody, if they're having a respiratory issue. PEEP valve considered when mechanically ventilating a patient with COPD. Trauma patients, cervical spine control, etc. Now, preparation for rapid sequence induction. We talk about a risk versus benefit analysis. We'll give you more of that in a second. Note and document the patient's GCS and neurologic exam prior to RSI. Adequate access to the patient. You need 360 degrees of access if possible, which means you have to take them out of the little tiny bathroom and get them someplace where you can actually work on them. Sometimes the best place is right in front of the back door of the ambulance, and you're better off to have them on a gurney that can be at a decent level, because very seldom when you go to the ER, very seldom do you find any of us intubating somebody by getting it down on the floor with the patient. Monitor is the same, you already do that. Pre-oxygenate, non-rebreather mask at a maximum flow rate in addition to the nasal cannula at 10 liters for at least 3 minutes prior to intubation. That would be ideal. Now, in a city environment, urban environment, even suburban, that's probably possible. You have enough people and enough oxygen. In a rural area with minimal amounts of personnel, you may not be able to do quite as much of that. If you're BVM assist, if their SpO2 is less than 94, if I'm unable to obtain sats of 94, consider alternate method of airway management, such as maybe adding a CPAP to them. After induction, turn up nasal cannula to 15 liters for apneic oxygenation. Remember, unless there's an obstruction to their airway, if you have high flow oxygen, lots of oxygen in your nasopharynx, it flows downhill to the low concentration. Ideally position patient head elevated to 15 degrees, ear aligned with the sternal notch. You have to put padding under the head and neck. If C-spine precautions are necessary, then the patient should have manual cervical inline stabilization, but C-spine precautions are not a contraindication to appropriate positioning. Remember, this is all inline. Brief the procedure with all participating personnel. We're going to be doing more, I'm going to be emphasizing our airway protocols next year in additional training and additional advanced airway stuff where you can practice these things. But getting all personnel, we're going to try to do a buddy system where you have a quote, an airway buddy, where you are working together. Document vital signs before pushing medications. Unless you have adequate assistance, don't do RSI. Induction medications, simplified. Etomidate, 0.3 milligram per kilo. Remember, the max is now 30 milligrams rather than 20. Alternative is ketamine, 2 milligrams per kilo, max 20. It's ideal for status, for reactive airway disease, concern for shock due to trauma, cardiac, etc. Now, if the patient is in shock, so their MAP is less than 65, systolic less than 90, the doses for induction agents should be cut in half, including etomidate. It still will work, but cut it in half. Succinyl choline, 1.5 milligram per kilo. Alternative rocuronium if sucks is contraindicated. Or in the case of Skamania County, they exclusively use rocuronium. Turn up nasal cannula to 15, a jaw thrust, waiting for paralysis, if there's no NPA or OPA in place. Routine use of cricoid pressure is not recommended. Continuous suction after fasciculation stop, or usually after about 30 seconds. With sucks, begin intubation, rocuronium, wait at least 60 seconds. It's good to have a timer on, so you can really tell that. Visualize the epiglottis. We recommend that intubation should routinely be performed with a bougie. If you get suboptimal visualization, remove cricoid. If you had cricoid pressure on it, stop it and do extra laryngeal manipulation. Move it around. You have to do that yourself. Change patient position, elevate head of bed, better suction, and sometimes put the laryngoscope in, bring it out. Change the laryngoscope blade, change the operator, you. King vision with channel blade, bougie preloaded. You can repeat sucks if you get inadequate relaxation. It probably means you missed the dose or you've got a bad batch. You don't need to repeat that with rocuronium. You've already got 45 minutes on the rocuronium. If intubation repeatedly unsuccessful, either insert iGel or do cric. And we have an addition to the cric change here. Treat bradycardia per protocol. So you note that lidocaine's not in there, and atropine as a preload is not in there. So the lidocaine, we didn't have enough evidence, enough scientific evidence that it really made any difference, and just one more thing to think about. So now it's very simple. Pre-oxygenate, position correctly, get all your equipment ready, treat with an induction agent, treat with a paralytic, intubate. Post-intubation, repeat vital signs, and post-intubation, first drug out of your box, I want to see fentanyl given. For an adult, 50 mics, maybe 100 mics if it's a giant person. We're treating pain and sedation at that point. They may not need sedation after that point. They may, that if you give enough, if you have fentanyl 50 to 100, now unless they're hypotensive, you wouldn't want to give them that. If they're hypotensive, consider giving them some ketamine. 0.5 milligram per kilo, repeated every 10 to 15. But then if you need sedation, if they're not reacting well to the fentanyl, or if you just want to do it, I'm not gonna be on anybody's back if they give if you give some midazolam after the fentanyl, but let's not sedate them before we give them some pain meds. Ventilation rate, no change in that. Cardiac arrest intubation, we threw this in because you don't generally need to give them any drugs to intubate them during cardiac arrest, except that, but you do need to have the right amount of equipment. And then, if the patient has trismus, because your CPR is so good, you can give a paralytic, but you don't need to give them a sedation at the time. You just need to give them a paralytic. Why waste your time on that? You give them the sedation after intubation, if they're waking up. I mean, or if they're reacting, especially if you've got now an ROSC, or if they get ROSC and they're still comatose and not breathing, and you want to intubate them. But if they have trismus, you may have to give them a paralytic. It's okay, it's covered in that. So, need for a long-term paralytic. Well, basically the need for a long-term paralytic is they're not responding to post-intubation treatment with fentanyl to good dosage and midazolam or ketamine. Then a long-term paralytic can be given, and rocuronium would be our preference of choice, although if you still have some vecuronium works too. And that is an alternative. The need is unable to ventilate patient due to chest rigidity or patient's asynchronous breathing. So if they're fighting your tube, and the patient is successfully intubated and not responding to maximum sedation and pain medicine. So, very seldom are you, so you don't see that anymore. Oh, I wanted to paralyze them for the long ride in from Battleground. Need to treat them. You need to treat them with pain meds first and sedation. They may not need. I want to see these guys wake up after their ROSC, because that changes that changes a lot about how we're going to take care of a post-cardiac arrest or any other case. If they're stroked and you end up intubating them and long-term paralyzing them, it's going to be forever before we can figure out how bad their stroke is. Okay. Recheck and document ET tube placement, every move or change in vital sign. We did give permission, by the way, if unable to establish or maintain adequate airway and ventilation, transport any patient, including trauma, to nearest hospital to obtain definitive airway control. I put that in there so you don't ever have to use it. you can take, you can always get an airway in there. Even if you have to do a surgical, for a trauma patient, if you have to do a surgical airway, you do a surgical airway. Okay, there will be, and right after, there's an advanced airway emergency RSI checklist. We want to start using checklists. Don't have to. We'll do more training next year on that too. But basically, we do like the helicopter medics do, is they have a checklist to go through, because they're used to doing the same thing the pilots do. Because remember, the pilots crash first. That's why they that's why they do the checklist. Pleural decompression, a little change. Rapidly deterring patient with a history of chest trauma, COPD, asthma, with decreased breath sounds, absent breath sounds, distended neck veins, asymmetrical movement or on inspiration, hyperexpanded chest, hyperresonance to percussion, etc. All the same findings we've always had for history of a tension pneumothorax. Now, insertion of a 4-inch over the needle catheter in the second intercostal space mid-clavicular line for average sized adults or pediatrics. Or in the 4th or 5th intercostal space just above the mid-axillary. So you've got anterior axillary line here where the pect is, you've got the posterior axillary line where the lats are, in between, there's no magic line, it's just an in-between space, is the mid-axillary line. In females, it's where the breast crease is on the side. Not underneath, but on the side. And that's just above the mid-axillary line. You insert it in, just straight in, over the top of the, once again, over the top of the rib. Remember, the ribs in this are running this way now, so you can feel the rib. Most of this stuff came out of the military because they have guys with big chests, because they have a lot of chest muscle. That's not our problem. Our problem is we just have big people. You know, the civilians, the average fat pad is a bit over 1.5 to 2.5 inches, and that's on the chest too. So if you can't feel the ribs, can't feel the space between the ribs, don't go for it. Go for over here. There's not as much fat out here, surprisingly. And this, the mid-axillary and just above the mid-axillary line they've done tests on cadavers and tests on real live people where they've done a CT scan at the same time, and you got about a 90% chance here, whereas in larger people you have about a under 50% chance here. So keep that in mind. Now, use it in, quote, life-threatening situation. I just don't want you testing it, you know, just for fun. Complications include local hematoma, cellulitis, cardiac laceration, and pneumothorax. And skinny people, why don't you use it on skinny people? Well, skinny people, because a 4-inch needle here might do a liver biopsy. So. Restraint of combative patients, sedation. Evaluate personnel needed to safely restrain the patient. Treat medical causes of combativeness like hypoxia. If cause of patient's agitation is suspected to be psychiatric, or if you don't know, then we're using Haldol, 2 to 5 milligrams IV or IM. May repeat to a total of 10. Now the alternative, Geodon, 10 milligrams IM only. You can repeat that if necessary to a max of 20. Now, if you think the agitation is simply due to drug ingestion, then you treat it with Versed. Versed, 2.5 to 5 milligrams, up to 5. Repeat to a max of 10. Now, then, and this is, remember, this is no change. then if you think, well, you started out using Haldol, and you've done a maximum dose, 10 milligrams, you're at 10, and they're still totally wacko, you can switch over to Versed and give that to the doc. Then you don't use Geodon and Haldol together. What about, I think this patient might be excited delirium. Your answer is to give Versed 10, follow that by Haldol 10, right then and there. I am. So what is my definition of excited delirium? Make it simple for you. If the patient is so agitated you require police or other people to hold them down, you can't start an IV, they're biting and spitting and fighting and pulling away from you and totally and you can't get an IV in, or they rip it out, just call them excited delirium and give them the drugs I am. Now, there's a recent study Mark found the other day that the best sedation for, in general, and this is an emergency department setting, for all comers, whether they were psychiatric or medication, was essentially 10 milligrams of Versed IM. So we'll keep that in mind. Pediatric doses, we have the pediatric patient doses for Haldol, for Versed, and remember, if they have EPS, the usual EPS, the worst EPS that they get usually with Haldol, and if you give adequate doses of Haldol, I don't see it as often, is akathisia, which is a creepy crawly, they can't sit still, they act like they're excited delirium. But I don't want them to have more Haldol in that case. In that case, if you think that the drug you just gave them made them really wacky, give them some Benadryl, and if that doesn't mellow them out, give them a little bit of Versed along with it. All right, because the surgeons are all excited about stop the bleeding, perhaps we should stop, bombs and things like that too. But wound packing. Wound packing is allowed under the national standards for EMTs as well. We haven't given it to EMRs, but so wound packing is used when conventional methods for hemorrhage control have failed. Now, the biggest thing about hemorrhage control is that do the simple things first. We have been teaching for years and years and years before they worried about tourniquets. Direct pressure stops most bleeding. When you have a wound that is gaping, which has things in, you need to get direct pressure on that, and direct pressure works out best by wound packing. And if you use combat gauze, which is gauze impregnated with hemostatic agent, okay, regular gauze works if you don't have it too. But you pack this, and we teach it, and we have sessions. We taught several sessions last year, I think it was, on wound packing, and there's all sorts of moulage kits and all, and you can take a great big piece of of beef haunch, and you have it oozing, and learn how to pack. This comes in a gauze roll, and you just peel it off, and you pack it in, and you peel more off, and you pack it in, and you peel, and you keep packing it in until it stops, and then you keep that pressure on it. And for junctional wounds, you do direct pressure. Sometimes, and some of you are very clever. We brought in one junctional wound this year with the EMT leaning elbow into the groin with gauze and stuff in there, and with that kept the bleeding down. Matter of fact, did a really good job on a femoral artery. So junctional bleeding, groin, axilla, wounds of the head, scalp, back, extremities, neck, chest, and abdomen, and head should not be, well, head as far as scalp, you have to be careful, because if they have a skull fracture in there, you could poke yourself with the bone fragments. Direct pressure to stop the bleeding, you just push the gauze, roll it, weighted pressure, hand, elbow, knee, and gloved hand, and into wound and tamponade, the bleeding source. Don't forget, appropriate personal protection. Gloves, face, eye protection, gown. If wound continues to bleed or ooze, continue packing and exerting direct pressure. Please tell the receiving physician how many gauze rolls you stuck into the hole. We like to try to get them all out when we do that. Okay, this I meant to have pop up earlier. This is the checkoff list, so you don't have to remember all those things. The transport to alternative mental health facility, hospital checkoff list. So you can just go through that, and it has the phone numbers and things like that on it too. County operating procedure, crime scene response. I don't think this has changed as much as we just emphasize not removing anything from the scene that's contaminated with blood. This may be evidence. They'll need evidence. So, and talks about being conscious of statements with the victim, specific garments, victim in a clean sheet when ready to transport, provide your name, agency, and contact information, investigating officer. Get a detailed report in case you're going to go to court. Don't offer your opinions or evaluations about the crime scene. And it may be a good idea to do an incident report, just so you have extra, these things usually go to court, like medical cases, usually go to court about 5 years after the event. So it's hard to remember if you don't document it sometimes. Any location can be or become a crime scene. So if something doesn't appear to be right, notify police. If law enforcement is not present, secure area and document what you see. Medical control, just a reiteration, the Peace House Southwest Medical Center's medical control for clarification of orders or patient disposition, disparity between pre-hospital protocols and private physician wishes, general medical information and controlled substances or treatment. If a patient is being transported to a facility outside of Clark County, medical control must be utilized for treatment concurrence while the EMS unit is within Clark County. You also let them know you're going to be transporting out, or they will tell you to go out. When transport unit is operating in Multnomah County, medical control is at Medical Resource Hospital, OHSU. Controlled medical treatments can be given without base station physician occurrence. There aren't very many controlled medical treatments anymore. So when you can't communicate, we've removed most of those things that you don't have to get. This is not a mother may I kind of system. Most of it is covered by your orders. Medical control will be contacting all trauma patients if diversion to a level 1 facility is anticipated. No, that's uncommon. So usually you contact medical control saying you've got a patient, and they'll say, well, we recommend if this pediatric patient is stable with this head injury that you continue transport to a pediatric facility in Portland. In general, we take probably 98% of all things at Southwest. Paramedic consult is required for field termination of ACLS. We talked about it. Diversion to Portland Area Hospital for trauma, burn, hyperbaric patient. Pediatric bruit and patient and parent or caregiver refusing treatment. Patient refusing care against medical advice. Okay. So, summary of changes. We already went through that. Universal patient care protocol, and so your summary of changes are all written down here. So it actually is fairly simple. Now, when do these orders take? These orders will be in full effect on the 1st of January. Now, that's because we have to upgrade 270 of you roughly on the orders, and by signing in today, you have signed that you have received the orders. Now, that means I probably couldn't give you an in-depth test on it, although there's almost no changes to what you're doing now. We're doing another one of these upgrades on Thursday, and I think the number of folk who have shown up here today will probably get about 2/3 or more of the medics upgraded now. And we're planning on at least one, if not two, makeup things for the elk hunters and persons who are not available this particular week. And I intend to have everybody up to all the medics up to speed by the 1st of January. Now, you say, well, do I have to wait until? No. Because you've been okayed on this. Oh, the other thing is that this all has to be filed with the state, and they usually take their own sweet time, even though we haven't changed anything really. It's just new to them. So we'll have that approval, but so if you're out there now and you've got a hyperkalemic patient, don't worry about the insulin glucose thing. You've been upgraded on that. You don't have to, it's not in your test. If I were to test you today, you'd say, no, I don't use that anymore. You don't have to use lidocaine or atropine when you're pre-medicating an RSI kid with asthma. You've got the correct dose now of etomidate. You can use all those things. I will not yell and holler and scream at you. Okay? So we'll just move this on. Then everyone will be up to speed, and theoretically, almost all of your compatriots in all the other counties will be working under the same basic guidelines too, with local control. Who has questions? Like, is lunch served or? No. Okay, now, I would ask you, as you get the electronic copies, you go through them and play with them and let us know if the hyperlinks aren't working or if they go to the wrong page. Because we have to, there's a lot of things to build this sort of thing. Okay, all right. Well, be careful out there.